So thank you. Good morning, good afternoon and good evening to everyone. Once again, we welcome a warm welcome on behalf of MYT, and we're very much looking forward to supporting you for today's session, Developing Campaign Effectiveness Outcome Measures. We'd like to open with a few housekeeping notes before handing over to Dr. Andreas Hasman. Please be aware that the sessions will be recorded. You'll be able to view the recordings after the event via the Health Campaign Effectiveness Coalition website. Please familiarise yourself with the programme, speakers and attendees and networking opportunities available on the virtual platform. All can be accessed from the navigational bar on the left-hand side of the homepage. We would like to encourage interaction throughout the conference, throughout the 2 days. Please use social media channels to promote and engage a wide audience with this event by tagging @HCE Coalition and using the collaborative action hashtag. During the session, please add your questions to the Zoom Q&A, which can be found at the bottom of Zoom or underneath the stream. You'll be able to see the questions posted already, upvote and add additional comments. We'll aim to answer as many of these questions in the session. And finally, the MYT team are here to help you with any technical difficulties. Please use the chat facility on Zoom or the chat facility on the platform, or email the team at events@myt.uk.com. I'm now delighted to hand over to Dr. Andreas Hasman to welcome you to today's session.
Thank you very much, Claire. Welcome everyone to this session on the measurement of program effectiveness. My name is Andreas Hasman. I work in the nutrition section at UNICEF in New York. The strength of a preventive nutrition and health program is its ability to deliver essential preventive health and nutrition services and interventions, and to respond effectively to disease outbreaks. In the post-COVID-19 era, effectiveness in delivery becomes perhaps more important as service delivery is scaled back up and health systems are built back better. But what do we mean by delivery effectiveness, and how do we measure that at country level? That is the focus of this session. Public health and nutrition programs typically rely on coverage when assessing and evaluating performance, and coverage continues to be used by decision makers for program planning as the default parameter of service delivery effectiveness. The effectiveness of community-based interventions is well documented, and such interventions contribute significantly to reducing morbidity and mortality. What is also clear, however, is that many community-based interventions are insufficient in scale-up and in reach. The benefits of some delivery programs do not reach enough children and often systematically miss children who are most exposed to risk, such as infections. This suggests that effectiveness is often suboptimal, and we need an effective way to measure and track effectiveness over time to enable changes that optimizes delivery. So although a summary measure of overall program performance is available in terms of coverage, and coverage often reflects a range of system strengths and weaknesses, it offers limited means to identify exactly what those strengths and weaknesses are. High overall coverage may thus mask poor service delivery performance in specific target populations, whereas low overall coverage provides a scarce indication as to what changes is needed in service delivery to optimize delivery. So there are significant gaps in our understanding of whether and why some community-based interventions are delivered more effectively than others. And to address such gaps, we need operational clarity on what constitutes an effective intervention delivery program and strategy. As a first step, we need to gain a more granular understanding of performance and effectiveness in these delivery programs and what it actually means. And this is what has been UNICEF's focus in a recent project that looked at delivery effectiveness. The project was funded by a sub-award from the Health Campaign Effectiveness Coalition, and its starting point was the Global Vitamin A Supplementation Program. The full report will be available shortly, and there is a virtual poster available for this meeting that goes into a little more detail about that project. But today I want to highlight one of the outcomes of the project, which is a conceptual framework from which we can describe delivery effectiveness. Next slide, please.
Hi, Sally. We can't see the slides at the moment.
Okay, yes, and then the next one, please. So in the project, we identified 11 effectiveness parameters, which may be relevant in the assessment and measurement of program effectiveness at country level. And based on consultations with program people and experts, we grouped these parameters according to importance. So in the project, we found that most important were equity, availability, access, community acceptance, and sustainability. But also of importance were service quality, clinical outcomes, responsiveness, efficiency, community awareness, and resilience. The definitions of all these parameters are available in our project report. Today, we will dig deeper into 4 of these effectiveness parameters, and they have been marked with red circles here. In a moment, Dr. Zewdie Birhanu, Associate Professor in the Faculty of Public Health at Jimma University in Ethiopia, will talk about the country experience of community acceptance and community awareness. After that, I will talk about equity as an effectiveness parameter, and later Olusola Oresanyu, Senior Country Technical Coordinator at the Malaria Consortium in Nigeria, will talk about sustainability in country programs. And at the end of the session, we will have hopefully a lot of time for discussion. But at this point, I will hand over to you, Dr. Zewdie, for your presentation on community acceptance and community awareness. Over to you.
Okay, thank you, Mr. Facilitator, Dr. Andreas, for introducing me. Hello, everyone. Good morning, good afternoon, good evening, wherever you are. I'm Zewdie speaking from Jimma University, School of Public Health, and I'm speaking on one of the parameters which already introduced, which is related to community acceptance and awareness as a measure of service delivery effectiveness. Next, please. Next slide. Yeah, thank you. So let me first define what community acceptance means. Okay. So community acceptance is generally referring to the extent to which committee members are approving and willing to use the service being delivered to them. So the key point or the key question is we have to ask whether the local population, the beneficiaries, are engaged in the design. That means including the inceptions, the initiation, and then the delivery of the intervention, including the implementation and the evaluation of the intervention. So in that case, we can address the felt needs and the priorities. So these are the questions that may very much relevant to acceptance. So acceptance is a key component in community participation, engagement, and in this empowerment. So basically, it also depends on the principles of community organization, where it is a matter of like fairness, justice. That means people or local communities have they should have their voices heard during the program designs. So community acceptance can be in fact seen from two extreme points, like when communities are actively demanding the services, value the services. That means which can be achieved through usually the bottom-up approach, when high-level engagement is there, and then when our intervention is actually address the priority need of the particular community. On the other hand, we can see lack of program acceptance.
Zewdie, I don't believe we can hear you at the moment. Can you just double check you're still connected with the session? Dr. Andreas Hasman, I believe we've actually, or Mr. Zewdie's just disconnected and will be reconnecting shortly. I'll just allow him just another moment.
Maybe we give him another moment.
I think he has reconnected, but he needs to unmute his microphone.
I think I'm disconnected because
you are muted, Dr. Zewdie.
Yeah, yes, I'm come back now because I'm using a stable connection. Electricity is not with us. So I was talking about the community acceptance, and that's very much important in program design. And another important issue is community awareness, where usually the first parameter where we have to measure whether our services, our programs are reached to the target audience. If we fail at that point, that means we cannot even talk about acceptance. So why this program these parameters are important is really obvious because one, if the program is not acceptable or to the target audience, whatever it is, regardless of the beauty it have, the perfection in design or whatever it is, it will not yield the expected outcomes. So it will not be sustainable. People may feel the manipulation and even resistance may develop, and for that matter, it's really important to look at the ways we can ensure community acceptance. Next, please. So one of the strategies we can ensure community acceptance is like increasing the dose of our intervention, especially in public health program, designing the programs in such ways that we can increase the frequency and the reach of our messages or whatever the product is one way. That means it gives better understanding, better knowledge, and then better acceptance. Another point is ensuring community engagement. The more the community engaged in the program, the more we get our programs or intervention get acceptance. So we have a ladder of community engagement. So the more we move to the high level community engagement, that means we are also ensuring the acceptance, and this is the key to must be key to program design. Next, please. Another point I want to raise is about acceptability. Is not it's really it's a continuum from pre-design, then during the intervention or the implementation, then post-implementation. So we have to look at across the program trajectory, across the program history. That means we can assess how people think from the very beginning as part of formative assessments. Then we have to keep doing, looking at how people feel and experience the programs. Then that's also an acceptance. And then after the program or the intervention is over or concluded, we have to again measure how people how the programs are acceptable to the beneficiaries, and we have different methodologies, especially these qualitative techniques like focus group discussion and then interview, and in most cases like direct observation gives more reliable measurement on acceptability. Still, validated tools like CAP measurement is also possible, but we have to really that means this acceptability is context specific, and our measurement must be sensitive to the local situations. That's one important point. Next, please. Next slide. Still it is there, okay.
Can you see? Is that okay?
Yeah, okay, thank you. So this is one point. So what are the issues and the consideration for decision is that, you know, parameters. Yeah, just concluding. And important point here is that
so I think we've lost Dr. Zewdie again. Maybe we.
He's still showing us on the call, but he's not responding, and he's definitely off mute. He has now disconnected.
Maybe we give him a moment longer to come back on the call.
So yes, he is currently disconnected, and is no longer on the call. Did you wish to move to the next presentation, or give him another moment to reconnect?
I think maybe we give him just a moment to see if he can reconnect. Otherwise, we can his final points can be made at the end. So I don't see him online anymore, and this is always a challenge with connectivity. Okay.
No, he hasn't been able to reconnect as of yet.
Okay, so maybe we go to the. I think this is his last slide. Can we just see if the next slide?
Yes.
Please?
Yes. Yes.
Yes. Can we go to the next slide? Yeah. No, it's a shame. We were just getting to the concluding part, but he will have another opportunity at the end of the presentations. Okay, so if I could have the next slide, please. I'll say a few words about equity. Equity as an effectiveness parameter. So this slide is just to place it within our framework. It came through in our project as an important parameter for effectiveness, and something that was also mentioned in the plenary discussion a moment ago. So next slide, please. Yes, and the next one. In terms of equity, we might ask, how can we best conceptualize and measure the effectiveness of a preventive public health program in terms of the ability of that program to promote equity? So that is really the key question. So equity is, of course, a central tenet in primary healthcare strengthening. However, it's also clear that primary healthcare models have lacked a way. Historically, they've lacked a way to effectively track progress, as well as relative effectiveness in promoting equity across different approaches and strategies. Traditionally, healthcare equity is viewed in a rather unidimensional way, with a focus on a single deprivation. For example, the prevalence of a poor outcome, such as children not receiving vitamin A supplementation. Comparing two groups, such as the poorest or the richest, or maybe those residing in an urban setting and those in a rural setting. We tend to look at absolute and relative differences in outcomes between those with the deprivation and those without. This is a simple way of illustrating the way we normally approach equity as an issue. Next slide, please. Here are some examples from the world of vitamin A supplementation, just to illustrate this point. And these next few slides all draw on data from most recent demographic and health surveys, DHS. When we look at uptake of the vitamin A supplement among the poorest and the richest children, as illustrated in this slide, in vitamin A priority countries, it's clear that there is significant inequities in programs. In most countries, poor children miss out on vitamin A supplementation far more often than richer children miss out. Difference in coverage between poorest and richest children may give us an indication of the level of the vitamin A supplementation program's ability to address inequity. So in this slide, some countries reach more children, they reach more poor children than rich children. But by and large, the main picture here is a picture of inequity favoring the disadvantaged. Next slide, please. Here, so this is another example of disparity that might indicate a program's effectiveness in terms of addressing inequities in delivery. Here we plot coverage of vitamin A in rural areas against coverage in urban areas. For a few countries, it's clear that children living in rural areas miss out on vitamin A supplementation more often than children in urban areas, which we would expect. But what is interesting here is that in most countries, there's no clear difference between the two groups, at least not at national level. This may be because there have been additional efforts in rural areas in some countries. And that then indicates an effective program, at least in terms of addressing the rural-urban inequity gap or equity gap. But as we saw in the previous slide, other measures such as household income, for specific countries, they may indicate the opposite. The point I wanted to make here is that in order for equity to make sense as a parameter of program effectiveness, we may have to look at disparities across several outcomes. So there are two problems with any unidimensional measure of inequity in a delivery program. First, the most disadvantaged children suffer not one deprivation, but actually multiple deprivations. Arguably, it is actually the experience of multiple deprivations that determines the degree of disadvantage. The second problem with unidimensional equity measures is that they tend not to communicate the underlying distribution of the deprivation within the population. For example, it may be that the prevalence of non-receipt of vitamin A supplementation is greater among children residing in households where the caregiver has no formal education, compared to children residing in households where caregivers have received at least a secondary education. While this is important, and it's an important observation, it fails to account for the proportion or absolute numbers of children residing in households with a caregiver with no formal education. So arguably, this information matters. A significant coverage gap between the least and best educated households could be interpreted differently if it is 1% or 40% of children residing in those non-education households. So to address these problems, we might adopt an alternative way of measuring inequity, which is based on a deprivation score. Next slide, please. The idea behind that is to group children according to the number of deprivations that they experience, drawing from a predetermined list of deprivations. So here we suggest focusing on deprivations relating to water source in the home, mother's education, household wealth, and receipt of either the DTP vaccine or a measles-containing vaccine. So looking still at non-receipt of vitamin A supplementation, next slide, please. We might call this zero dose VAS. This is how we can present those findings for individual countries, using Pakistan as an example here. Here we have all children divided into groups depending on how many deprivations of the 5 listed before they are experiencing. And we are depicting that against the prevalence of zero-dose VAS for each of those groups. In the graph underneath, we have the distribution of children across the 6 groups, from 0 deprivation to 5 deprivations. So looking at this, how can we conclude anything about the effectiveness of a delivery program? Well, we can look at the overall percentage that are not receiving the supplement. We can also look at the absolute and relative difference in prevalence between the group with 0 deprivations and 5 deprivations. And we can look at the underlying distribution. Of course, there might be more ways of interpreting this, but those would be ways we could conceptualize equity based on this. So I won't go into much more detail on that. Just to say that that all the measures of equity or inequity I presented here today, both the unidimensional measures and the multiple deprivation scores that I've just talked about, they all rely on data from population-based surveys, which is obviously a disadvantage at the country level, where such surveys may not be very frequent and cannot be used to base decisions relating to the program on. However, at country level, there may be better and more frequent collected data available, and I'd be interested to hear more about that from you, whether that is actually the case. So in conclusion, I have argued here that equity is an important parameter of effectiveness and something that should be brought into any assessment of the effectiveness of a program. But it's also not very straightforward to measure equity. A multidimensional measure that includes multiple deprivations may be a way forward, although that measure will have to be developed and further developed and strengthened from what I've presented here today. I will leave it here and hand over to Dr. Sola for the last presentation.
Right, thank you very much, Andreas. Yeah, so I'll take it from here, talking about sustainability as a measure of delivery effectiveness in public health programs. Next slide. Yeah, so this is the outline, and next slide, please. So we know that there is a growing interest and effort among researchers, evaluators, and even community partners to understand sustainability of effective public health interventions. And the term itself, sustainability, is very broad and interconnected. And many times the definition is dependent on people's perspective. And in planning for sustainability, planning for sustainability requires a really clear understanding of the concept itself, and also the operational indicators that can be used to monitor sustainability over time. It also requires the use of programmatic approaches and strategies that favor long-term program maintenance. So this chart that you see just shows, the many factors that are intertwined in the concept of sustainability. 3 main factors, actually. the environment, the economy, and social factors. But all these they have an interplay between all of them. Next slide, please. So how do we define sustainability? The term itself is one term that there is very little consensus on how it should be defined. And it's used many times interchangeably with continuation, program maintenance, durability, long-term, appropriation, or even institutionalization, among many others. And we know that although there are some differences in each term, but they all connote the use of program components and activities beyond their initial funding period, and sometimes even the continuation of the outcomes of that program. Now, three main constructs have been described for sustainability by Scherer and Daring et al. And they talk about continuation of health benefits, especially when the program is delivered to individuals, health benefits after the initial program funding ends. And then the second one talks about continuation of the program activities within one or more organization. And then the last one talks about building of a community capacity to develop and then deliver programs after the initial funding period has expired. Next slide, please. So I wanted to flag some other definitions just to show the fact that there is really no consensus around it, but there are similarities around different definitions of sustainability. So the first one there talks about capacity to maintain program services, and at a level that will continue to provide prevention and treatment for health problems even after the termination of major financial or technical assistance from external donor. The second one talks about, again, the maintenance of health benefits and with a component of time added to it. And then the next one talks about continuous use of program components and activities for continued achievement of desirable program and population outcomes. And then the last one, again, talks about maintaining programming and its benefits over a long period of time. Next slide. And the question is why measure sustainability? And like I said earlier, there is an increasing interest. Donors and funders are interested in finding out whether their investments are lasting beyond, the initial funding period, or whether those investments just fizzle out after the seed grant is spent. And we also know that sustainability itself is an important research topic within the broader context of translational and dissemination research. So if an intervention is effective, you need to be able to translate that intervention, scale it up, and also propose for the adoption of that intervention. And sustainability is one factor that would be considered before that intervention can diffuse. It's also important for researchers and program planners to maximize the benefits that have been garnered from studying the sustainability of evidence-informed interventions over time. A focus on sustainability requires considering potential loss of investment for organizations and people in the event that the intervention with perceived or actual benefits are not sustained. Again, another reason is that new interventions may actually encounter diminished community support and trust, given that when that intervention was introduced, there's a history attached to the fact that an intervention was abruptly discontinued or inappropriately terminated. And then also discontinuation of intervention without planning or intention causes disillusionment of participants and poses obstacle to future community mobilization efforts. Next slide. So what are the variables for measuring sustainability? Quite a number of variables have been described. These were pulled together from Shara and Daring et al. And they described independent variables as well as dependent variables. The independent variable, again, related to those three concepts that I described earlier, talking about project design and implementation factors. What is the characteristic of, or what are the characteristics of that intervention itself? Is it easy to implement? Is it cheap? Is it easily adaptable? Is it flexible? Or is it expensive? The second variable are the factors within the organization that is implementing that intervention, and they relate to internal capacity or even the perception of benefits of that intervention by those who are implementing it themselves. And then the last independent factor relates to the broader community environment. And Zewdie talked about community acceptability earlier, and partnership that can support capacity to continue to deliver that intervention. And then you have also the dependent variables, which are related to the outcomes, whether the benefit or the outcome for the consumers can continue, or continues after the intervention has ended, or also maintaining community level partnership or coalitions that were developed during the funded program. Another one is continuing the program activity or components of the original intervention. So again, the intervention really doesn't necessarily have to continue as a whole, but do you have components of that program that are continuing even beyond the intervention itself? And then also maintaining new organizational practices or procedures that were started during the program implementation, sustaining attention to the issue or problem, and also program diffusion and replication in other sites. Those are dependent variables that can be measured. Next slide, please. So, but what are the challenges with measuring sustainability? And like I said earlier, sustainability is a really broad concept, and there are variations in conceptualizing it because it's quite broad. And then also there's a lack of consensus on measurement framework for sustainability. There's difficult reporting approaches and timing of research on sustainability as well. And there are also methodological challenges related to measuring sustainability, as well as limitation in the availability of context-specific data when you want to measure sustainability. So I will conclude by saying that we know that sustainability is an established parameter for program effectiveness. However, to inform program and policy decision, it must be paired with meaningful measures, because if you can't pair it with measures that can be used to measure it, and then it becomes difficult to really use it as a parameter for program effectiveness. Secondly, timing of research on sustainability should extend beyond program implementation to be able to really assess the actual continuation of the program activity or outcome. And also, organizational or community contexts are important in determining appropriate measures and methods. And lastly, an effectiveness measure for sustainability needs to capture long-term affordability, both not only for the health system, but also to individuals. Next slide. And next. So thank you for your time.
Thank you very much, Dr. Sola, for a very well-researched presentation. Dr. Zewdie, you are back, and I just wanted to give you an opportunity to make some final points that you were not able to make before. Do you want to come in here with your conclusions relating to community acceptance and awareness?
Thank you, Dr. Andreas. So I really want to say sorry for the interruption, and my final point or message is that acceptability and awareness is an important variable in an effectiveness of service delivery. So one important thing is they are dependent on contexts and so many variation could be there across settings and cultures and so on. So program planners and policymakers should look at what acceptability means and whose acceptabilities are more important and how it affects the program implementation and so on in particular contexts. So another important point is, it's already said, in fact, the previous speaker, the community engagement. I would like to emphasize that, community engagement, participation and empowerment is really a path to enhancing community acceptance and where we can ensure the community feel a sense of ownership and the program could be successful. Otherwise, if the program is, whatever the intervention, it could be a perfect design, perfect in terms of technical and so on. But if the community or the target audience would not accept it, it's nothing. Nothing. So finally, there is one quote I didn't get the time to mention it. Nothing about me without me. Very interesting quote. That is really to say, whatever the program is, whatever the intervention is, unless we engage the target beneficiaries at all levels across the program process, it may not be successful, and that is one important point that we have to note. Thank you, Dr. Andreas.
Thank you so much for those comments and for your presentation. We don't have much time, unfortunately, for the discussion, but just maybe we can address a couple of questions. Martha is asking Dr. Oresanyu, how should partners and stakeholders help national and subnational health authorities strengthen their ownership and governance as essential functions to make interventions sustainable? Any reflections on that?
Yeah, thanks for that question. I think one key way to do that is to build local capacity. Because when we talk about sustainability, it's either maintaining components of an intervention beyond the timing of the funding for that intervention by external donors, or the outcomes from that intervention beyond the lifespan of the program. And so if it's important that partners and stakeholders build local capacity to continue that intervention beyond the lifespan of the funding stream that may be coming into that program. And also in the design of the project, it's important to also consider affordability and make use of local resources so that it's not designed in such a way that it's so expensive that when funding is withdrawn, the government or the communities cannot continue to implement that program. So I would say build local capacity and to consider affordability in the design of interventions. Thank you.
Great. Thank you for that answer. Maybe just building on that. You mentioned in your presentation that there is not much consensus about sustainability and how to measure. And to what extent do you think that is important to get to that consensus and one definition of sustainability? Or is it a matter of adapting our understandings of sustainability to the context?
Yeah, I agree that yes, there's really no consensus, but I'm not sure whether we can all agree to one definition of sustainability, because sustainability itself is very broad and there are so many parts to it. And again, it depends on the perspective from which you're looking at it. Are you looking at it from the perspective of the intervention, or you're looking at it from the perspective of the outcome, or you're looking at it from the perspective of the capacity of the people who are going to deliver that intervention. But I think, like you said, for any government to be able to measure, sustainability, there has to be an understanding, a common understanding of everyone who is involved in that program, to say, okay, this program we want to implement, what are we looking at in terms of sustainability? Are we looking at sustaining some components of it? Are we looking at maintaining coverage, and not just the coverage of that intervention, but also to be able to maintain the impact of that intervention on those who are beneficiaries of it. So it has to be context specific, like you said. We need to look at who are the people, what is the environment like, and what are the social factors that will contribute to sustainability, and be able to agree upfront what are we looking at for each program intervention in terms of sustainability.
Great, thank you very much. Dr. Zewdie, maybe I can ask you, as well as also Sola and the participants, listening to going through the issues in this session. What is there a role for the HCE coalition in further exploring and testing these outcome measures in the coming years? Is there any suggestions to what the coalition can focus on as we move forward in this discussion? Dr. Zewdie, do you want to answer first?
Okay, thank you. So as I already said, the concept of acceptability is more of a context bound and context specific, and yet it is very important element in program effectiveness, delivery effectiveness. And now I think it is really important to explore what acceptance mean in different contexts. What are the sub dimensions? Really, acceptance is a very broad concept, and there are some specific aspects and the dimension of acceptability that must be explored in different contexts. So in the future, I think the focus must be given on ways of exploring, plus what strategies can ensure acceptance of the interventions, whose acceptance is really important from the implementer perspective, from the community side, and so on. So additionally, I feel it's also good to maybe synthesize evidences. What are the best available evidences that can inform us what acceptability means, and what strategies are effective to increase program acceptance. So in the future, these things must be, I feel it should get attention, and because unless the program is acceptable, I would say, it's really meaningless to send the worst stage. And the community engagement as well. It must be, again, the center of the heart of the program design. And then what kind of strategies can promote community engagement is, what are the best practices to engage communities and service delivery? There are so many questions that should be explored. Yeah.
Wonderful. Thank you so much for that response. And we are running out of time, unfortunately, and we will have to continue the discussion in the days and weeks following the meeting. Claire, can I hand over to you to take us out? I just want to thank all the both the panelists and all the participants for a very good session. So thanks so much for your contributions. Thank you.
Thank you very much. And just a final word from MYT, and that is that the next sessions will begin in around 10 minutes time. So that will be at 10 o'clock EDT time. And those are titled Session D, Experiences in Campaign Integration. Session E is Geospatial Data Solutions for Improved Health Campaign Efficiency and Effectiveness. And Session F, Campaign Integration, with PHC systems. So if you all kindly return to the platform and choose your next session, we'll see you in around 10 minutes time. So thank you again to all our speakers today and for your attending. We'll see you again shortly.